Welcome back, and you're still watching Good Morning Nigeria. And before we begin our conversation, which borders on malaria vaccine implementation, let's take this background report by Oyeyemi Ajayi.
Health experts say malaria still poses an unacceptable health burden, causing about 608,000 deaths worldwide in 2022. 78% of whom were children below age 5 in sub-Saharan Africa. So the introduction of the malaria vaccines signifies a new hope in the global fight to end malaria. In December 2023, the World Health Organization fully approved rollout and use of the second malaria vaccine, R21 Matrix M, to prevent malaria among under 5 children living in high endemic areas. This came 2 years after recommending the first malaria vaccine, RSSAS01, for the same population. About 28 African countries have moved to adopt the malaria vaccines within their national malaria elimination programs from 2024, and 18 of them include Nigeria. Nigeria officially began its malaria vaccine rollout in November 2024, focusing on the R21 vaccine for children under 1 year old, with Kebbi and Bayelsa states as the initial high-burden priority areas. The program, supported by Gavi, UNICEF and WHO, involves a 4-dose schedule integrated into routine immunization, aiming to reduce the country's world highest malaria burden. The vaccine is said to be integrated into the existing national program on immunization to ensure sustainability. However, health analysts have decried limited initial supply of 1 million doses, believed to be insufficient for the entire nation, which has the world's highest malaria burden, necessitating a phased approach. The vaccines are said to be currently available for free to children aged 5 to 11 months in Kebbi and Bayelsa states through primary health care centers. The rollout targets high-burden areas with a 4-dose regime, with plans to expand to other states. Now, how far with the malaria vaccination implementation? Talking about the pilot states and what efforts are being made to replicate in other states. Our guests in the studio will be answering these questions and more shortly.
Many thanks, Oyeyemi Ajayi, for that background report. Now joining us for the discussion on malaria vaccine implementation. Let me introduce Dr. Emmanuel Shekrau, Head of Case Management at the National Malaria Elimination Program, Federal Ministry of Health and Social Welfare. Many thanks for joining us, Doctor.
Thank you.
Thank you so much. And also joining us is Dr. Oluwafumilayo Ibikunle. She's the Public Health Technical Malaria Consortium. Thanks so much for joining us.
Thank you very much.
So let's begin this conversation with Dr. Shekaru. We all know that according to statistics, actually, Nigeria carries one of the world's highest malaria burden. And, people are asking, why did it take so long, for vaccine deployment to begin in Nigeria?
All right, thank you very much for that question. Like you know, the malaria vaccine had over the years undergone, various degrees of trial. And it was only in October 2022 that the World Health Organization made the pronouncement or recommendation for countries in endemic malaria countries to begin rollout of the vaccine upon the multi-country pilots that were conducted in Kenya, Ghana, and Malawi, which, provided the necessary evidence to commence deployment of the vaccine in malaria endemic countries. So, following that pronouncement and the availability of now a malaria vaccine, which has over the years been clamored for, countries were now encouraged to commence deployment. And the deployment was encouraged to be alongside other malaria preventive intervention and other interventions, such as the use of insecticide-treated nets, seasonal malaria chemoprevention, among other interventions. So after which countries were now, called upon to access this vaccine, and also considering the global scarcity, allocations were made to countries to commence deployment of the vaccine. So it's not like it took long for Nigeria to...
I asked because 2022 to 2026 is 4 years.
Oh, wow. Okay, so, well, the country didn't start deployment in 2026. We had since commenced deployment in 2024, and of course it's based on the availability of this vaccine. So it was at that time the country was allotted about 1 million doses as talked about in the report. And by then we started the deployment. Of course, 1 million doses wasn't going to go around the whole country, and it was based on looking at certain considerations, data, demography, and the need for equity and other things. We ensured the highest burden state in the country, which is Kebbi State, was prioritized because the surveys over the years had continued to demonstrate or show that Kebbi has the highest burden, and we needed to deploy unnecessary intervention to bring down that burden in Kebbi State.
Bayelsa?
And then Bayelsa, of course, the southern part of the country. We looked at other criteria working with the National Primary Healthcare Development Agency. There are certain criteria that are looked at, including the zero dosing and other things, and also looking at the number of doses that were available in country. So logistics were also considered. Because looking at Kebbi, of course, Kebbi is the northern part of the country, and we needed another state with a burden, considerable burden, and looking at other immunization criteria. Looking at Bayelsa being a smaller state, and the doses left from Kebbi, looking at the number of children that will be covered in Kebbi, we now felt Bayelsa, which is
would be a good pilot state.
Yeah, exactly.
Fantastic. Many thanks, Dr.
Yeah, and not also to correct, not a pilot state. What we did was, what we started was a phased deployment of the vaccine. So we are not piloting. We didn't pilot the vaccine. The pilot had been conducted across Africa, and we were just to adopt, and it was a phased deployment that we started.
All right, many thanks, Dr. Shekarau. Let's get to Dr. Ebunkule now. I want you to speak about that phase, which was for Bayelsa and Kebbi. What was the success like, and what are the results from that deployment of the malaria vaccine?
In those two states, initially, there was some uptake of the vaccine, but not as much as was expected to be uptaken. And so there were a lot of thoughts around how best to ensure there was increased uptake of malaria vaccine by eligible children, knowing the benefits and knowing that it's best to make it work with other malaria prevention interventions for children under 5. So a number of partners kept involved in different projects to see how best to support the government in improving the uptake. So one of such is this enhanced project, in which we know from studies that apart from being an age-based deployment, if you increase uptake around the period of seasonality, that's during the rainy season where you have the peak malaria transmission, you have maximum protection. So can we see if we can drive that in Kebbi State, knowing that it's one of the states that has the seasonality of malaria, especially for a limited number of months. If we try to push for more uptake around that period, can we see the impact on the health of the children? And the project was mainly to have more pre-season demand creation, timely demand creation, community level driven demand creation, and then encouraging the mothers to take the vaccine more during the peak season of malaria transmission in Bayelsa.
So what was it like? The children who took it, did they come down with malaria? Are they free, completely free? Is it a vaccine you take once in a lifetime and you're free from malaria? How does it all work? And how did it work, actually? From 2024 till now, what can you say about what the vaccine did?
It's been known and studied had shown that if you take malaria vaccine along with other prevention malaria interventions, it reduces malaria episodes among children under 5, thereby reducing the burden and severity and mortality among them. And for a child to be protected, they have to take their 4 doses, which, based on the schedule in the country, they start at 5 months and then take their first, they call it the primer doses, first 5, 6, 7, 1 month apart. And then after 6 months, they take the last dose. And that kind of protects. And with use of other prevention interventions, like Dr. Ashakarao talked about, the use sleeping under the insecticide-treated nets, seasonal malaria chemo prevention campaigns that have been done mostly in the northern state, that's this, the Sahel region of the country. We've seen a drop in malaria cases among those children. Mothers have attested to improvements in their child survival and well-being. Communities are saying that, yes, there's a reduction in the cases. But it's not just a standalone. You have to take it along with other malaria prevention interventions.
What other malaria preventions?
Okay.
Can you specify?
Okay, for malaria, to control malaria in the country or across the world, we have what we call the prevention interventions. So it could either be chemo prevention. Chemo prevention means you're taking drugs to prevent you from coming down with malaria. So for children under 5 in Nigeria right now, we have what they call the seasonal malaria chemo prevention, and it's given to children between the ages of 3 to 59 months in the Sahel region states. And right now in Nigeria, we have about 20 to 21 states where that is being deployed. A period during the peak malaria season, some give it monthly. It's given monthly for like 4 or 5 cycles based on the states and based on their the peak malaria transmission period in those states. Other ones is what they call the perennial malaria chemo prevention, in which other states apart from the Sahel states where children are also given, but that right now had not been a full national policy. Another form of chemo prevention is among pregnant women, that intermittent pregnancy treatment for pregnant women, where they are given anti-malaria doses, SP doses, during pregnancy to prevent them from coming down malaria and then from their children having low birth children or their babies dying. And apart from that, we have what they've called the vector control. And one of that is the use of insecticide-treated nets. You expect mothers or children or vulnerable population or even the old population to be sleeping under the nets. And another vector control is the indoor residual spraying, where you fleet a surface area in the house with insecticide around inside and outside of indoor residual spray, where you spray the insecticide just to prevent malaria biting or laying on the walls. And then if you now come down, we talk about the case management. And in case management, you have to be tested with either rapid diagnostic test and to confirm you have malaria, because a lot of viral infections somehow simulate malaria. And once you're confirmed, to be treated with an artemisinin-based treatment. So it's a combination of interventions.
All right, many thanks,
Yes,
Dr.
let's bring in Dr. Shekaro now into this conversation. You mentioned Ghana, Kenya, and also Malawi. So I would like you to tell us, what kind of lessons did you learn from the implementation that took place in that country? Because I believe they don't have the population that we have in Nigeria. And how did you implement their blueprint here in Nigeria? And let's talk about acceptability. There's this conspiracy about vaccines and all that, especially in the north. So how were you able to encourage, enlighten the people, the women and the parents to bring their children for the vaccination itself?
All right, thank you for that question. So for Ghana, Malawi, and Kenya, of course, countries learned from the pilot that was conducted there, because the pilot there provided guidance on the scheduling of the vaccines. For example, in Ghana, the commencement of the vaccine was from 6 months. Their schedule that they deployed was 6 months, 7 months, 8 months, and then I think about 18th month or thereabout. While for Malawi, it was from 5 months, 6 months, 7 months, and the booster at about that 18 month or so. So the scheduling we learned from those countries, and also the need for the national program on immunization, which is our own National Primary Healthcare Development Agency, and the National Malaria Control Programs to work in synergy in order to deploy this intervention. You know, primarily the National Malaria Program has a mandate of deploying malaria intervention, while deployment of immunization, it's a primary mandate of the MPI programs. And so that lesson in those countries on the need to work jointly and understand the terrain, guide on data, and all of that was established. And also some of the models they deployed, for example, the social behavioral communication in order to sensitize the communities, and all of that were also established in order to minimize vaccine hesitancy and other things. So all those lessons were learned from those countries, which enabled other malaria endemic countries to adopt. And it's not a game of numbers of whether the burden or all that. It's just the model strategy on how to deploy that vaccine, and that was very helpful for countries to adopt this vaccine. Then on
acceptability,
the acceptability in the country, and generally, well, I say fortunately or unfortunately, a lot of persons, even our locals in communities, understand malaria to be a major burden. And when you bring intervention, especially when it has to do with malaria, a lot of times we see that acceptability. For example, when we started the seasonal malaria chemo prevention that she talked about in Katsina State, we were able to see that feasibility and acceptability of the intervention, because mothers, even when you leave them out, they will sort that care that their child, and they're seeing other children that benefited from that being prevented from coming down with malaria. No more frequent, no more frequent visits to malaria, no more, not going to school and all of things. So there was that acceptability generally, and it was seen to be feasible. So it wasn't any different for the malaria vaccine. It was accepted. However, because it has to do with going to the facilities, and it's a multi-dose at multi-interval, there was that, the coverage was not that optimum, which led to the need to see how to, increase the uptake through this particular project that was carried out.
Right.
That's the enhanced
So
project.
2026 now, the plan is to cover more states.
Yeah, absolutely.
Cover more states. But you see, I'll take you back to the 2024 rollout. Was there a follow-up on the children? Because when Dr. Ibukulin was talking, she said mothers said their children were no longer coming down with malaria. But was there a clinical study? Was there an approach by the team that deployed the vaccine to follow up on these children to check if there was reactions, what really happened to the children after the vaccines, what was the change? I mean, just so that we're absolutely sure that, the vaccine was doing more good.
No, absolutely. When you're deploying such, we work jointly with the experts on immunization, like the National Primary Healthcare Agency and the State Primary Healthcare Agency with the national and the state malaria programs. That is always the model, that they need to follow up, they need to look at reactions. Mothers are sensitized. If your child is given this vaccine, make sure you to observe. Are there any reactions, and all
So what's the report?
Yeah, the result is good in that there were no such reports of harmful effects of on the vaccine to the children. And like I told you, parents are eager to have that because they were seeing that their children were not coming down with fever and, you know, malaria as a whole. As a matter of fact, it was, again, especially with this project, it was seen that the malaria vaccine increased the uptake of other routine immunization, you know, in those states that where we are deploying them. So you will realize that it was doing more of good.
What's the plan for 2026? More states to be covered, or you're sticking with the Kebbi and Bayelsa states?
Yeah, absolutely. As I speak with you, the plans for Ondo states to be part of the states have been concluded. In fact, they've commenced rollout. And Bauchi State, as I'm talking to you, I have colleagues from National Primary Healthcare Agency and the National Malaria Program that are already there to support Bauchi State in the deployment of the vaccine. So our plan initially was by now the whole country should have commenced the deployment of this vaccine, but however, availability, cost, and other things have not been, you know, favorable for us to do that scale up. We had our scale up plan to have more states to have commenced by now, as it were from our previous plan, was for us to have had practically all the states in the country commence the deployment.
I know funding is going to be an issue.
Absolutely.
Sustainability of, you know, of these vaccines. So how much is Nigeria contributing versus the Gavi, World Health Organization, and of course the Vaccine Alliance? How much is Nigeria contributing?
Yes, so I know for that I may not have exact details
yes.
because you know the National Primary Care Development Agency has that mandate, and logistical and other things, they have those figures and details to provide. So I don't exactly have that information.
All right. Many thanks, Dr. Shekara. I would like our viewers to know they can be part of this conversation. Of course, would like to hear your feedback, your comments, suggestions, questions, whatever it is. I'm sure our guest will respond adequately to them. The number is on the screen. Feel free to send SMS or WhatsApp messages. Dr. Ebukele, I'll return to you. He's talked about funding. He's talked about other issues that have stalled, you know, the plans, you know, to get the whole country covered. You know, being able to sustain this initiative is what would actually make us malaria free, right? Yeah. So, depending on donors, depending on funding from international partners and all, is that the way to go with a program like this, such that, I mean, we know what malaria is doing to our children and even adults?
Okay, thank you. I think the fight against malaria, it's a fight that everybody needs to be involved in. And one thing we learned from this project is if you have a strong community-driven demand creation where you have community leaders, prominent community figures, health workers putting their support to it, putting their support to the project or to the program, it's boosted. So there's a need for collaboration to have that community level driven demand creation, to collaborate with the government and MPTD and NMEP, even at the state level, you know, the State's Primary Healthcare Board, State Malaria Elimination Program, health workers working together with donors and partners working together. One thing we learned from this project is when we started implementing with SMC, Cycle 1 and 2, and we saw a boost, a number of other partners joined in to improve the coverage across all LGAs in the states. And that showed synergy, and that's why we have a success story of uptake. So it's a fight that everybody should be involved in, and if we can continue that collaboration across all layers, community, governments and partners, it's a fight we can win.
It's a fight you can win, and you know, as the malaria vaccine implementation spreads across the country, let's talk about children insurgency bedeviled areas, you know, these affected areas where, and some of the hard to reach areas like in the riverine areas and nomadic populations also. So how are you going to reach this number of people to be able to give them the vaccine?
Okay.
What plans do you have? Do you have on ground to ensure that all children across the country get the vaccine?
I know presently government has a plan to reach all children. That's why I kept saying that community level driven. Insurgency had been like a part of us for a while now, but there are interventions being deployed in those communities, and they've leveraged on the community members. Some we call them the community health workers. Could be health workers that are from that locality, that they know themselves, leveraging and working with them at improved or sustained health interventions. And I know immunization activities is still being done in areas with insurgencies, it's still being done in hard-to-reach areas. For immunization, I know there's what they call the outreaches, and that's something that the project kind of supported more, to have more RI mobile outreaches to go to where we have hotspots for vaccination. That's where we have a large number of unvaccinated or under-vaccinated children. And it's the health workers that the community are used to. It's the community health workers telling them, please come and take. It's the community leaders, the emir saying, I give my child, you to come and take this vaccine. So I know government has plans, as social behavioral communication, SBCC, demand creation, working with the community in such areas. It's one of the ways or key strategic ways that the government is working on and we can improve on to reach hard-to-reach areas.
All right, hard-to-reach areas will be covered. That's good to know, Dr. Shekarau. I'd like you to, enlighten us about, the age groups that are, capable, or rather, that are supposed to take this vaccine. What's the age limit? And then speak about, you talked about primary healthcare centers earlier. Speak about the ability of primary healthcare centers to store these vaccines, and if they have adequate and sufficient healthcare, providers to administer it. Because we've had issues with vaccines. People talk about a certain temperature that vaccines should be stored, else they'll become important and all of that. So
cold chain storage.
Yeah. So speak about all of that with this malaria. So it doesn't look like we're administering vaccines that do not have ability to actually take the malaria away.
Yeah, so thank you very much. So for the storage, it's an established fact that the National Primary Healthcare Development Agency, working with the state primary healthcare agencies as well as development partners, we have that cold chain system operational in the country, right from the national vaccine storage site in Abuja and how they are really preserved using all necessary cold chain system, even at the health facility level, having those carriers that, preserve these medications. A lot of primary healthcare centers having solars for preservation of these, vaccines in the country that are being deployed. And, it's not only malaria vaccine that we're talking about here. There has been other vaccines in the country, which is being managed by the National Primary Healthcare Development Agency. So for the malaria vaccine, we just leverage on that platform and the inclusion of this vaccine into the immunization schedule in the country. So basically, that was it. And for the age, I'll just summarize by saying it's for children less than 2 years of age, because we have seen adults, clamoring for it, or even older children being talked about. They need the vaccine, they need that. So, it's those children of immunizable age group. And for the malaria vaccine, it starts from 5 months, and that's the first dose for the Nigerian immunization schedule, 5 months, 6 months, 7 months, and the booster by the 15th month of age. But children from first dosing, I think, has been increased to commence at least at before 11 months of age. So basically that.
Let's talk about manpower now. You know, health workers across the country. How are they being trained differently for this vaccine implementation? Do you have enough manpower to do that?
Yeah, so, well, for enough manpower to a large extent, especially in centers that are, it's not every primary health care center or every health post that deploys this vaccine. So for centers that deploy this vaccine, there are trained manpower, and, there are schedules and other mechanisms put in place to deploy vaccines generally. So capacities of those healthcare providers are built. For instance, for the malaria vaccine, before its deployment, there is a robust training plan that is put in place to build the capacity of the healthcare providers to ensure proper and adequate deployment by impacting the necessary and requisite knowledge and skills on how to administer the vaccine, and also even monitor any reactions if there is, and encouraging caregivers to ensure they adhere to the schedules that have been marked for this vaccine.
Okay, Mrs. Olufunmilayo, what safeguards are in place to sort of prevent stock outs or diversion of vaccines? It happens sometimes. How are you protecting? What safeguards are there to protect the vaccines from being stolen?
Okay.
We can't rule that out. Yes.
First of all, for them to be stolen, they have to have like a very solid cold chain system to maintain the potency of the vaccine. Because that's why it's not, like Dr. Shakara mentioned, it's not all health facility or health posts that can deliver immunization, because you have to have that, you must maintain the cold chain structure or the cold chain system. So there's some health facilities that have their cold, the solar refrigerators to store. There's some that have the cold boxes that they use to collect the number of vaccines they need per vaccination, per immunization session. And before they commence immunization, they have a target based on their population. So the health workers already have, that's one very good thing about the immunization structure of the country, being supported by the MPHCD and the state, is that the health workers know their target population. They can, down to the number of children that are expected to take each of the antigens. So that exact number is what they will collect per immunization session. So I feel right now there's a good structure maintaining, safeguarding, stealing. Unlike drugs that it's easy to take and go and sell, but if you break that cold chain system, the vaccine will lose its potency. I just give it.
All right, Dr. Ibukele, I'd like to stay with you. I didn't want to ask Dr. Shekara this because he works for the Federal Ministry of Health, but I mean, you work with a private health organization. Speak about what Nigeria could do in terms of production of vaccines. You talked about unavailability. I mean, if there was availability, I'm sure from 2024 we should have, gone further than we have at the moment. Now, can Nigeria really get to that point where we do not depend on the Western world, for vaccines? What should we be doing?
For Nigeria to start producing vaccine, it takes a process. The number of, I think, WHO accredited, how do they put it? Accredited standards you have to meet. And I know right now for NAFDAC, they are trying to ensure that production of some drugs in the country, for example, anti-malaria drugs, are being produced in the country and they are meeting the WHO accredited standards. So I think we're already on the pathway, but for us to be a country to be producing, there are a number of stipulated WHO accreditation of standards for the world to be able to accept. It's not just producing for Nigeria, but for the world to be able to accept and say this vaccine is good enough for any child in the world, any child, eligible child. So we're on the pathway, but we are not yet.
When you talk about the standards, where are we lacking? What should we be doing? Where should we, try to get it right? Or you think it's something impossible?
It's not impossible. Like I said, we've started making anti-malaria drugs in Nigeria. So we've reached a milestone, a very significant milestone. It's difficult now to import for maximum countrywide uptake of anti-malaria. There are laws against you importing anti-malaria drugs. You have to procure the ones WHO accredited drugs being manufactured in Nigeria. For vaccine, there are a lot of immunological studies. There are a lot of immunological
Studies or
steps
yes,
that need to be taken. And I'm not sure if we have such labs already existing in Nigeria. I'm not sure, so I can't say authoritatively. But like we've started with drugs, we're on the path, and we'll soon get there.
if you soon
say
get
we're on
there,
the path.
I would like to know if, because mostly we wait for the Western world to, bring things like that to Africa and all that, and we have doctors, microbiologists all over the country, ready to do these things, and they need training. So I believe Inyere will also want to know if donor funding declines, does Nigeria have the sustainability plan to continue procurement? You are from the private sector. If donor funding declines, because we saw what Trump did with the others.
Okay, I know the Honorable Minister for Health and Social Welfare, one of his main cardinal agenda is for the sustainability of health interventions in the country, saying how all programs, different programs, child health programs, maternal health programs, all different health programs can be funded by government funding. So as the funding from donor or from donors are kind of reducing, it's trying to divert us to look at more of sustainability directions. And an example is a primary healthcare provision fund that he wrote an open letter saying some funds are being sent to health facilities to help them improve the health services. So I could say we, as a country, we're on the path of, based on the good leadership, we're on the path of sustainability of our health services. In terms of, even if they are reducing, let's start looking inward. And the source of the basic healthcare provision fund is the 1% from the Federation Fund. So it's trying to say, let's look inwards, let's use our funds. And the basic health provision fund adds so many pathways. Those that are going to the primary health care facilities, the part of it is also going for the health insurance. So gradually, with the leadership, there's this sustainability being entrenched into the system.
Okay,
All right.
Dr. Shekaru, can you talk on that?
Yeah, so like you already mentioned, the current leadership we have has been quite proactive at seeing to sustainability and over-reliant on donor funding to provide interventions. There's this presidential value chain initiative, the PVAC, that has been inaugurated by the federal government under this current leadership of the president and the coordinating minister. Have been quite proactive. Like she had mentioned, as I speak with you now, we have WHO pre-qualified, firms in the country that are producing anti-malarials that are already WHO pre-qualified. For example, the sulfadoxine pyrimethamine, SP for pregnant women, that has been done, and the other ACTs as well. Is on the, and just late last year, before now, nets are not manufactured in country. The insecticide-treated nets. We didn't have WHO pre-qualified firms, but as I speak to you, last year, that has commenced, and it was under the drive of this current coordinating Minister of Health and Social Welfare, Professor Pate, who is also a global acclaimed leader on provision of public health intervention. And you'll also recall that during some of the stop work orders by the United States government, the country was proactive by ensuring that services are not interrupted for provision of all intervention, not just malaria.
Okay. Many thanks.
Generally, the country is on the pathway to seeing how that can be done. And also the good news, like she mentioned, is the fact that NAFDAC, as we speak, are nearing the maturity level 4, or such that when we attain such, we are able, that means we have the capacity, the facility to pre-qualify, medications and other,
all right,
commodities.
Dr. Shekara, thank you so much for that explanation. But I would like you to speak about conspiracy theories and vaccines. I mean, with HPV, so many stories about it. Now malaria, of course, since it's coming from the Western world, I mean, a lot of stories are tied to them. Speak about how we can begin to build trust in this whole process. You are a health professional. Do you actually do you check these vaccines? Are there some kind of scientific study? Are there some kind of testing or whatever it is to be sure that some of these theories are actually not true? Or you just dispel them because, I mean, they're coming from the Western world? I mean, you just have to take it hook, line, and sinker.
Yeah, so that's why we talked about NAFDAC. They have that mandate of ensuring quality assured commodities. They do some level of quality assurance checks on whichever commodity is coming in country, and also narrowing down to malaria, for example. That's why we don't just deploy interventions. We ensure the conduct of some sort of feasibility, acceptability studies before, deployment of any malaria intervention. She talked about perennial malaria chemoprevention, which we are just about to commence in the southern part of the country. We needed to carry out this study, feasibility, acceptability, and even the efficacy of those intervention. It's oftentimes conducted by the country. Like every year, even the anti-malarials that we get from outside the country, we conduct therapeutic efficacy studies to establish the effectiveness and efficacy of those anti-malaria commodities before they are, deployed. So the country generally don't just deploy intervention once they just come, we just accept them. We have to carry out studies, including the human behavior and acceptability, to see how we can really, deploy a strategy that works for us and not just accepting whatever recommendations come.
You said checks are done, but we still have fake drugs. I can't speak for vaccines, but I mean, we still have fake drugs in the market. So how do we still get all of that with all of these checks you're talking about?
But you and I know that counterfeits are markedly reduced since NAFDAC commenced, operations fully and all of that. The incidences of counterfeits, still occurs, but at very minimal level, especially if you go to public health facilities. And that's why we always encourage this. We have interventions in public health facilities provided by the government and oftentimes free. But what we often see is the patronage of the private. While we have free interventions, in the public sector. So that's why whenever we have this opportunity to talk, we encourage that public health facilities where we have quality assured interventions, or, you know, incidents of counterfeits, even in Western world, you still have them. It's not like we are not encouraging that, and like, you know, the government is doing all to markedly reduce or even stop the incidences of having counterfeits out there. So, yeah, checks I know are really being carried out. How some of those things may filter out, we wouldn't know. But the truth is, NAFDAC works, you know, as much as possible to carry out. I am speaking from the malaria point of view, and I know that those are really being done. You know, even for rapid diagnostic tests, we do quality assurance and all of those things.
Talking about rapid diagnostic tests, you know, usually when they do that, they tell people that you have malaria and typhoid at the same time, and people start treating typhoid and malaria at the same time, because as far as I know, I'm not a medical personnel, but there should be a viral something for typhoid before it is established. And this rapid, most of the time when you go for that, they tell you have malaria and typhoid. Can those two diseases be present at the same time in a human body?
And detected with the rapid diagnostic
yes.
kits.
So those are some of those.
Yes, because you're here, I really want to get clarification
So
on
those
that.
are some of
Because a
those.
friend just came to my house and told me she has malaria and typhoid. I said, how is that possible? So can you clarify on that?
Those are some of those shabby practices that are still of major concern. The malaria typhoid syndrome, it's something that it has been here with us for ages, and we are really, and the rapid diagnostic test I'm talking about, it's primarily for malaria, for example. So I wouldn't know how they would now join it together with the typhoid bits. They just, I think, you know, again, some of, especially in sometimes in the private setting and even in the public setting, some of our healthcare providers, that's why we're doing everything possible to build capacity of healthcare providers, especially on management of fever. Fever oftentimes, of course, can be caused by a lot of, you know, factors or viruses or bacteria, and not just blaming it on two diseases all the time. Most times when people have fever, it's just easy to blame it on either malaria or typhoid. Sometimes when people call to tell me, or they tell me that they say they have typhoid, I just jokingly tell them that means you have been eating shit. You know, so
yes,
and all of that. So you cannot, and they can diagnose them of typhoid today. By next week again, they'll tell them it's still the same malaria and typhoid. So even if you have to get a reinfection, it takes incubation time. So you will realize that it's just wrong diagnosis going on out there.
Let's also talk about wrong treatment, and I'd like to get to Dr. Ibukunle now. I know a lot of women who just give malaria drugs once it's the beginning of a school term. They tell you it's to prevent malaria. I don't know if that practice is ideal. And then, like he said, some facilities don't even test, or some people don't even test. Once there's a fever or your body changes, you go for malaria drugs. So speak about all of that. And
it could be stress at times.
Absolutely. It could be stress. Yeah, you're correct.
I keep telling people
it could be stress. Like, look and see how she's speaking. She has a flu. And she will have all symptoms similar to malaria, even with the flu. Even with long day of stressful work, you will have headache, you will have even feverish feeling. Then we have a lot of viruses that are oftentimes self-limiting. Whether or not you treat them, with taking rest and drinking a lot of water, they go. So sometimes when people blame it on malaria and then they take medication, because that viral illness will either way go,
they think
so they think they have treated themselves.
So speak about that, taking malaria even when you do malaria drugs, even when you don't have malaria.
Yeah. So okay, maybe she.
Okay. That's one of the. I think that's one of the key fight that NMEP is leading. That don't just be taking anti-malaria drugs. Make sure you are tested, and then when it is confirmed, you are given the anti-malaria.
Without typhoid.
Without typhoid. That combination, everybody has a title of the organism that the salmonella species. Everybody has that title because of we hit from different sources. So everybody has a particular title. So they just say a little title and they say, oh, you have typhoid. And for chemo prevention, for the northern part, that's why they're pushing the seasonal malaria chemo prevention, that if a child takes the full course of anti-malaria monthly for 4 or 5 months based on the states, they are protected. And in the southern states, that now they are considering to commence the perennial malaria chemo prevention. So that there are schedules to that, but not just arbitrarily taking anti-malaria, because it covers or shades people to do thorough clinical questioning and clocking of their patients to know, is
What's
it another
the problem?
Another problem? Because, for example, Lassa fever simulates malaria. COVID simulates a bit of malaria. And if you don't do a proper clocking, you'll be able to differentiate. You just give everybody malaria. But now, and the fight for the NMEP pushing is, let's treat actual malaria cases, not just any fever. Stress could cause it. If you get overstressed and you've not slept in days, you will run a fever.
All right, I think I want you to speak about practices that can,
let me
prevent.
also quickly chip in concerning what you talked about for school children when they're going there. Although that is also unfolding, it's one of the interventions we want to commence, called the intermittent preventive treatment in school children. But the usual practice of giving an actual anti-malaria to children going to school is a wrong practice, just to put it out there. It's a very wrong practice. What we encourage is the use of insecticide-treated nets. Children, when going back to school, especially boarding school, should go with a net, and that way they are preventing, but not just giving any anti-malarial to say you want to prevent. There is, and for chemo prevention, especially as pertains to malaria, you don't use a drug that is meant for treatment. The actual, when person is diagnosed and found to be positive, you don't use that same drug for prevention. So that's where the mistake comes in. Like the seasonal malaria chemo prevention we talk about is a particular medication meant for that. And even for the intermittent preventive treatment in school children that the WHO just recommended in 2022, which we are currently piloting in Sokoto and Cross River State with some promising results. Once that is done, that's why I tell you that we don't just deploy intervention once they are pronounced. We carry out some in-country study before.
All right,
Yes, now you know. I know you're worried about about your children. Now you know, so you know what to do if they're going back to school. We'll take a break. We'll be right back. Don't go away.
Many thanks for staying with us. It's still Good Morning Nigeria, live on the network service of the NTA. And our guests are still very much with us. I guess we'll just take some of the messages that we have before we continue with the conversation. This one says, Good morning, Nigeria. Thank you for airing such a topic at this time. My own reservation is the fact that vaccines are usually for children under 5 years. Why is this so different that only children below 2 years are considered? The other children need the vaccines too. That's coming from Omololu BA. It says, God bless NTA and Nigeria. Thank you so much, Omololu. God bless you too. Another one says, it's interesting to know the malaria vaccine rollout is gradually becoming a reality. That's from Rotarian Akomonu Azubike in Aba. And finally, we have, Good morning, NTA. My name is Samuel Solomon from Gombe. I think this is a welcome development. Here in Gombe, we have a lot of malaria cases. Children dying at a younger age. How fast can we get the vaccine in our state? Also, can children of 8 and above be vaccinated?
sure they will get you soon because the minister is from Gombe State. No, it's from Bauchi. Actually, they are connected. Okay, let me read the ones I have. From Mohammed Awal Musa, Afame Green World Observers Limited. Kano, he said, how can Nigeria best engage traditional, religious, and community leaders to endorse the 4-dose malaria vaccine schedule? Good morning, Nigeria. And Usman Abdul Razak said, Nigeria and other African countries should prioritize investing in local research and pharmaceutical production so that we can develop and manufacture our own vaccines. Strengthening our healthcare independence will build trust, promote self-reliance, and secure our future. And this one said, good morning. Can the vaccine be used by pregnant women? No. Another one said, good morning, presenters and the 2 doctors in the house. I want to appreciate doctors for giving detailed explanation on the vaccine for Plasmodium, which causes malaria disease. We have 4 to 5 species of Plasmodium. My question is, does this vaccine contain all antigens to stimulate the production of antibodies for all the Plasmodium? Primary healthcare facilities are where people access health services, mostly immunization program, but some suffer a lot in storing vaccine in the right temperature because of lack of storage facilities, e.g. solar refrigerator. What is the fate of communities getting potent vaccine from such facilities? Dr. Shekaro?
Yeah, so, well, I think we're starting with the last one where we talked about, you know, whether the vaccine is targeting every other species. You know, in sub-Saharan Africa, the implicated species for that cause the fatal form of malaria is the Plasmodium falciparum. And it's also, for example, in Nigeria, from all surveys we've carried out, responsible for over 97% of malaria cases. In fact, some of those species are not even found like really in Africa, for example, or in tropical regions like the vivax, and the other ones like the Malaria and Ovale tend to run more of chronic cause, not like really responsible for the, you know, frequent episodes of malaria that we have. So falciparum is what is responsible for the fatal form and severe form of malaria that leads to death, especially in children under 5. And so they need to be more focused on that particular species. And on the increasing access to these vaccines, you know, the federal government has always been on top of this to ensure that there is that master plan or the need to have every ward have a standard, you know, PHC being established there in order to have access to the, you know, illnesses and not just malaria. And the vaccine mainly, like we know, a lot of interventions. It's not just for the malaria vaccines. Targets the children under 5s, and it's for obvious reasons. You know, for them, their immune system is still they are most vulnerable because their immune system is not capable enough to fight these diseases. For example, you and I, adults, over the years, after the age of 5, you have been exposed to malaria over years. The repeated exposure you have had, the body has, over the years, developed partial immunity against malaria due to those repeated exposures, such that when this parasite enters the system, the immune system is able to detect it and fight it back. And so you and I, ideally, even if you calm down with malaria, it shouldn't be more than once or twice at most in a year, and not the regular incidents that we see persons treating themselves of malaria practically every month or every 2 weeks. You are not treating malaria. And that's the reason why the need for prompt diagnosis and point-of-care testing is now made available. It's available. That's before now, if you have, in fact, that's before 2010, you have to undergo microscopy before. But now we have rapid diagnostic tests in pharmacy outlets. Even you and I can buy, and when, you know, put through, you will be able to test yourself. It's just the way some persons, maybe you have diabetics, they just punch in and get some pinch of blood and you test yourself. So that is available in order to conduct a rapid test, and it gives a reliable result that when it's positive, you treat. When it's negative, sort for other causes. Try to patronize facilities, conduct full blood count or other tests, and actually confirm. Because repeatedly exposing yourself to these medications, it can be dangerous. When you consume a medication that you don't require, it will attack other things. It will, when it enters the body, ideally, if you take an anti-malaria, when it enters the system, it will be looking for those parasites and it will be wiping them off. If it does not see that, it will, of course, look for other cells, normal cells or organs, and attack them. And that's why we are having a lot of incidences of increased kidney failure, liver, and all of those things. So that's why we sensitize the general public when we have this opportunity, like in this medium now, in the NTA that has a very wide coverage. We want to discourage indiscriminate use of not just antimalarials, even analgesics and antibiotics should be avoided once you have not really been diagnosed for it through some proper tests. And like we said, even if not in for malaria, for example, there's access to these testing facilities that you can quickly enter and get yourself
When
tested.
are you getting to Gombe?
No, Gombe, I'm surprised because it's one of those states where, for example, we have a major global fund support where they are, sometimes, like we already said, a lot of those things might not be malaria. So he's saying they have a lot of malaria. But I know in Gombe State, for example, we have conducted insecticide-treated nets mass campaign. Nets have been shared in communities.
What about the vaccination?
Well, for the vaccine, it's not yet there.
It's not yet there.
And just to re-emphasize, we've talked about it in the course of this discussion, the vaccine alone will not provide you 100% protection.
From malaria.
Yeah, from malaria. So let people get it clear out there so that they don't leave other preventive intervention.
And it is
just
for
focus.
children, not for adults.
It's for children, not for adults. Thank you very much. It's for children, not for adults, and even children less than certain age group. And even when they get it, even when they get the full 4 doses, you get from 5 months, 6 months, 7 months, and a booster at about 15 months of age, it should still be continued with other malaria intervention. When it's time for seasonal malaria chemo prevention, like in Gombe State, they benefit from seasonal malaria chemo prevention every year. At least for almost every year, I personally go to Gombe State. I know that they are benefiting from that. We have shared net, it should be utilized. So for now that the vaccine is not yet in Gombe State and other states, we have other routine interventions ongoing. When somebody has a fever, they should quickly present at health facilities, get tested, and when positive, they receive an ACT.
Okay, talking about coordination, most of these malaria problems are in the grassroots itself.
Absolutely.
And these things cannot be possible without the subnationals. So how is the federal government, coordinating with the subnationals to ensure that there's uniform implementation of the vaccine for these children? Children, I keep saying children because I believe some of them listening to us who want to go and get the vaccine as adults. It will not work for you. It's for children. So how are they coordinating, between the states and local governments, all the structures of governance? How are they coordinating for the full implementation when it spreads across the country?
Yes, so in fact, basically from how the system operates, from the national level to the federal level, majorly, we provide more of technical guidance, like adopting strategies after conducting certain pilots, making it a guide or a policy, which the states now adopt for implementation. And even from the legislative point of view, health is in the concurrent list. So the states usually deploy intervention, haven't adopted the strategy that be the guidance of the national. So a lot of times those implementations are coordinated alongside the states, and also the local governments. For example, for malaria beats, we have state malaria elimination programs. Even at the LGA level, we have local government malaria focal points who are responsible for coordinating and seeing to the day-to-day provision of interventions.
All right, many thanks, Dr. Shekara. As we begin to round up this conversation, Dr. Ebukele, I'd like you to speak about practices that could keep us healthy and away from malaria. We've talked about the insecticide nets, you know, a number of times repeatedly, but speak about other practices. I mean, just like a reminder, you know, to people on how to keep their environments, you know, free from mosquitoes, how to stay healthy, and, you know, prevent some of these complications, especially malaria.
Okay, thank you. First of all, for a key thing for prevention of any form of illness is to ensure you are boosting your natural immunity, and such things would be to eat a well-balanced diet, keep your environment clean, and for malaria, avoid puddles of water. Rest, it's very key, and all the interventions that are available in terms of, there are so many public health interventions that if people uptake them, it helps to improve their health. For example, for malaria, the use of insecticide-treated nets, sleeping under the net. When there's seasonal malaria chemoprevention, let your child take the complete dose, the number of doses, the cycles for that round for the year. For mothers, that's why we have the family planning, space your children, the number of times you give birth to children. There's so many interventions that could be done, and if you're feeling ill, please go to a nearest health facility and get tested. Once you're tested and confirmed for malaria, be treated, but stop indiscriminate use of drugs. It's not for your own benefit or for the child's benefit. If there's malaria vaccine in your community, encourage mothers to take it, because like Dr. Shekara said, because the children have not built immunity, so the highest burden of malaria is among children under 5. So that's why I love interventions. See, a number of interventions, different public health interventions are targeted at children, are targeted at pregnant women. Even for a pregnant woman, while you go for your ANC, ensure you take that your SP monthly. I know a lot of women, after they've had 1 or 2 pregnancies, they feel, oh, I understand how ANC runs, but go regularly because of the health of your unborn child, to take for your normal ANC, for your own health, and then all the interventions be given to you. They give them tetanus toxoid. They're also given SP monthly to prevent you coming down from malaria, to protect your child, for you to have an healthy baby. And with that, we'll live an health-free.
And diet, of course, is very important.
Yes.
Okay. But what about the health practitioners? I think you should speak to them, because, I mean, we have health practitioners who don't do tests. Once you just present, doctor, I feel this, okay, it's malaria. Well, maybe not with public health, those in public facilities, but you see it in private facilities a lot of time, or places where they don't even have the diagnostic kits, they don't
like
have
chemists
and all that. They just recommend drugs and all. So what can we do in that regard?
I know the National Malaria Elimination Program is leading. You know, a lot of effort had been put into the public sector, and we're seeing result from that. And right now there is a drive into the private sector, more with the PPMVs, because they are more closer to the community. They are the first point of call for community members, and there's a lot of drive for them to ensure that they are being tested before they administer anti-malaria drugs.
Not prevention before.
Yeah, it's not just administering any drug. So there's a lot of work being done, led by NMEP and partners, to ensure that we work closely with the PPMVs, we work closely with the private sector, and ensure that the standard case management of malaria is being upheld across the country.
Okay, Dr. Shekaro, as we round up, we have some minutes to go. In the next 3 or 5 years, where do you see this vaccine implementation? And if the rollout underperforms, who is held responsible for it?
That's a big one.
That's a big one, of course.
Yeah, so, well, like, like you might be aware, or like we will be making, public very soon. Our current strategic plan for malaria has just expired last year, and a new strategic plan has been developed, which is going to be disseminated very soon, and malaria vaccine comes out very strongly as one of those interventions that will be deployed, and we try to see to reach about 2026 to 2030. We intend to see how these vaccines can actually go around. And one of the challenges is not even not the country not being interested, and the fact that we get some level of support and just some level of counterparts that we require from our own end. But the vaccine itself, there's still a global scarcity of those vaccines. Okay. Because, of course, the companies that manufacture those vaccines technology transfer hasn't really happened such that you can have generics of those vaccines available out there. So that technology transfer hasn't really happened, and there's still some level of global scarcity
You think that's deliberate?
Eh?
The global scarcity?
Well,
could that be deliberate?
I wouldn't exactly know. It could also be as a result of purchasing power, because those vaccines...
Considering the fact that some of these countries do not need the vaccines themselves, so... Well,
I wouldn't know, but the one I'm aware of is that there's still the global scarcity of those vaccines. We were able to get some more stocks, and the reason why we're able to scale up now to Ondo State and Bauchi states of recent. So currently we have about 4 states but other states are also being prepped towards deploying
somebody is asking when will it get to Niger State?
Tell him very soon.
Okay. Listening, I'm sure.
Okay, so that's it. So yeah, the country is geared towards having those vaccines. But what I don't want the general public to do or to take to mind is whether they must have those vaccines for them to be able to benefit, protect themselves.
Okay.
We have, like in Niger State that just talked about, they know we have been conducting seasonal malaria chemo prevention. They just had mass distribution of nets across the states just late last year, they had it. And prompt diagnosis and treatment facilities are also being made available across facilities in Niger State.
Okay.
So they should take advantage of all other interventions. Because the malaria vaccine alone, just to re-emphasize, cannot protect you 100%.
Okay. Dr. Emmanuel Shekaro, Head of Case Management, National Malaria Elimination Program, Federal Ministry of Health and Social Welfare. Thank you so much for your clarification, to Nigerians on all these and other diseases at the same time. We deeply appreciate you. We hope you come back when we call you the next time.
Thank you so much.
Okay, and Dr. Oluwa Fumilayo Ibukule, Public Health Technical Malaria Consortium. We appreciate you. Thank you so much for talking to the mothers, actually, so that, the public awareness is very necessary. And for people who are afraid that their children might be just hearing, we thank you so much for coming. We appreciate you.
Thank you.
And that's Good Morning Nigeria for today. Thank you so much for watching. I am Joma Yusuf. Another topic will be up tomorrow.
I'm Henry John. Live locked on the NTA and stay safe.